Good morning, everyone. Thank you for joining us. For today's session, Summit is proud to partner with the Cleveland Clinic. We will discuss the future of healthcare based on Dr. Adam Myers' insights and observations from the Cleveland Clinic. As well, we will explore how healthcare will change and how it will affect organizations and their healthcare benefits. We do have the Q&A feature available today, so you can submit questions through that option. If there's time at the end of the session, those questions will get addressed. You may also submit any questions to us via email at marketing@yoursummit.com. I will display that email address again near the end of our session. As well, for part 2 of our series next week, we will be responding to some of the questions we receive. So let's get started today. We have 2 guests joining us. Our first is Dr. Adam Myers. Dr. Myers started at the Cleveland Clinic in June of 2018. His role is new to the clinic and encompasses leadership of the ambulatory practices spanning across all ages, the urgent cares express care clinics, as well as the hospitalist teams. He also plays a key enterprise role as the lead for care model design efforts and the community health strategies for the clinic. Prior to joining the clinic, Dr. Myers served as a senior executive in multiple different complex integrated health systems. A New York City native, Myers is board certified in family medicine, fellowship trained in obstetrics, and has a master's in healthcare management from Harvard University. He is the immediate past chair of the American Hospital Association Board Level Committee for Clinical Leadership and is currently a commissioner on the Board of Joint Commission. Dr. Myers is an accomplished clinician, business leader, speaker, and humanitarian. He has earned numerous professional credentials, including the status of fellow with the American College of Healthcare Executives, the American Institute of Healthcare Quality, and the American Association of Family Physicians. He holds additional board certification in healthcare quality management and patient safety, and he is a certified professional in healthcare management risk. Our next panelist is Todd Rolland. Todd serves as president of Summit's employee benefits practice. Having been with the company since its founding, he has tackled the most unique and complex employee benefits situations. His experience is diverse and spans multiple industries. This perspective enables him to mitigate risk and guide clients to time-tested and creative solutions. Todd's professional designations include Certified Employee Benefits Specialist, Registered Employee Benefits Consultant, Retirement Plans Associate, and Group Benefits Associate. And now I will pass it on to Todd to begin our session.
Thank you, Megan. And thank you, Dr. Myers, for attending today. We're honored, we're thankful. We have a very unique opportunity this morning in that we have a professional that sees through a lens that offers great clinical side expertise, but at the same time, due to his responsibilities and the landscape in which he's worked, Dr. Myers also sees through the lens of a business executive as well. So we've got clinical expertise coupled with business expertise, and that represents a different type of professional for us. So we're thankful that you're here, Dr. Myers, and we're anxious to hear what you have to say. As Megan had mentioned, we will address some of the questions if we have time at the end. If not, we will be addressing those via email and at the beginning of the next session. So with that, I'll turn it over to you, Dr. Myers. Thank you.
Thank you, Todd. I appreciate that very much.
Sure.
So these are certainly uncertain times. And as we move through today and then next week and have some questions and answers, we'll try to bring a little bit of insight into where we have been in the world of healthcare, where we are now, and where I think at least we might be headed. And so next slide, please. You've probably seen these numbers before, and they've been updated since 2013, but the trend is still the same. Since 1980, the U.S. healthcare spending has outpaced all the other top 11 industrialized countries in the world from a percent of GDP. In 2013, it was 17.1%. Now we're up above 18%. And it's not by a small margin, in fact. Next slide, please. Now, if the outcomes followed that, and we were top in the world from the standpoint of a lot of different health outcomes that matter, like care process, access, administrative efficiency, equity, and importantly, healthcare outcomes like life expectancy, then we might say that we're getting our value out of it, but we're not. We're number 11 out of 11. Number one by far in spend, and number 11 out of 11. Next slide, please. So a little bit of insight into this. This slide is interesting in that it shows the healthcare spend and the social spend on what we call the social determinants of health, the things that involve upstream capabilities for people to be employed, to focus on prevention, to focus on having good transportation and good healthy access to care. If you see, there are actually some countries on the left-hand side of the graph that spend a larger percentage of their overall GDP on the combination of these two things. But what you'll note is that ours is, again, the highest percentage discretely on the blue bar, which is acute healthcare spend or the healthcare spend. So the other countries seem to be focusing a bit more on the social side of an infrastructure standpoint and a little less on the treatment of disease from a spend standpoint. Next slide, please.
Dr. Myers, if you don't mind, I might interject here just for a moment and a couple of observations that I think are interesting. As we look at those industrialized countries and the percentage of GDP that they're spending on healthcare, and we also consider outcomes, results that we all want, which is a great outcome for any of us that need care. It's really interesting to me to see that some of the industrialized countries that are spending the least are also experiencing the greatest outcomes because they're focusing on certain areas that are making a difference. So that's an interesting observation to me. And then another observation as it relates to social determinants. My observation here in the United States is in many of our larger cities, mid-sized, and equally as important, perhaps more important in small rural communities, is this idea that many of the people that really need the care face such social challenges that they're never able to adequately access the healthcare system. And so I've seen at the World Congress on Healthcare, Chicago as an example was talking about their strategy and infrastructure there to address some of these social detriments. So they actually have a transportation system that focuses on clinicians that focus on the need for folks, and then a transportation system that deploys those resources out to make sure that that population is able to access the care efficiently. So I think that's just an area that a lot of folks don't think about a lot, but it's just a huge, has huge influence here. So
couldn't agree more. You know, for instance, one of our sites of care that happens to be in one of those vulnerable communities where transportation is a big deal. Just at that one location last year, we provided 50,000 free rides to come for healthcare appointments.
wow.
So to try to mitigate that social determinant. So as
Interesting.
far as a percentage of the overall federal budget, in 1975, you can see Social Security and healthcare represented about 34%. In 2017, Social Security combined with our healthcare spend on a federal level exceeds 51% of the entire federal budget. And that has not gotten better since 2017. And so that leaves 49% or so for every other component of spend for the US federal budget. Next slide, please.
Wow.
So in summary, we're the most expensive of the top 11 industrialized countries on a percent of GDP and on a per capita spend per person. We also have the lowest overall value ranking, meaning the outcomes don't match the spend. And in a world where we have finite resources, very finite resources, and what we all perceive as infinite needs in a variety of different ways, it is important for us to think a little bit about how are we putting our resources where they're most effective. Next slide, please. So let's talk a little bit more about some of the differences between the US healthcare expenditure and other high-income countries. There was an article in the Journal of American Medical Association in 2018 that showed that the utilization of basic care and imaging are really not different in other countries. So from a utilization standpoint of the basic stuff, not a big difference. Now, far less preventative healthcare is performed in the United States. We focus more on treatment of disease than promotion of health here as a norm. There's less penetration of advanced directives, which means we're less prospective about how we face end-of-life decisions and how we want to manage our transition out of this place, so to speak. And then we have a higher utilization of quaternary, the most complex interventions that are out there. But at the end of the day, the primary contributor to the delta in spend are really our prices and rates of hospitalization. Next slide, please.
Dr. Myers, if I could, this is one that hits, it hits home with certainly our firm as an advisory firm. It hits home with a lot of the employer population out there listening to your content today. So if you don't mind, I'd like to just talk about this for a moment. The idea revolving around a home-based model of care. And when I think about a medical home, I think about some of the centers of excellence that are defined as centers of excellence throughout the country, of which Cleveland Clinic is one of those, Mayo is one of those, and others. And with that model, we've got great collaboration, great information flow between providers in terms of being in the know as it relates to pharma and all the things, all the comorbidities that patient may be dealing with. You all are in the know, you're collaborating, you're able to respond quickly, effectively, and of course the quality outcomes is what we see from that. Your type of model seems is different in terms of the prices and really what's being charged out there. So we have this fee-for-service billing in a lot of the nonprofit sectors and even some other for-profit sectors. And I know that when we benchmark with other countries and so forth, we have better technology, certainly. I like to think that our providers are better. But this pricing, this inflationary trend based on pricing is extremely important to our clients. The idea of transparency and being able to understand what goes into a price is critically important for them. And of course, today we have limited resources available to really understand what that price means. So do you have just a basic thought, and then we'll go on to your next slide?
Yeah, I think through the rest of the presentation and then a little bit next week as well, we're going to talk a little bit about how we've bent the cost curve here at the Cleveland Clinic. The employee health plan reports to me as well from a clinical perspective, from a programming and benefit design perspective. We have over 90,000 employees worldwide at the Cleveland Clinic, and our traditional bump year over year was originally in line with everyone else's escalation rate of 7 to 9% year over year spend for a self-insured employee plan. But what we found is through a variety of things that we're going to talk about today briefly, but then whet your appetite for next week, we've lowered that spend to where in some years it's been 0, and in other years we're averaging somewhere around 2% increase. So beating the national norms quite a bit, with all in an industry where frankly utilization for healthcare providers is usually higher when they treat themselves than most other industries as well. So there's a variety of different ways that you can approach the utilization and the spend, and we'll certainly be diving into some of that.
Yeah. Okay, thank you.
You bet. On this slide, Zeke Emanuel, who many of you have read some of his work, he published in August of 2019 a paper in the New York Times where he said that while the U.S. represents only about 4% of the world's population and 50% of the drug spend, the U.S. per capita spend is $1,443 in the U.S. versus $940 in Switzerland. And that's the second highest. So It's not like we're even shooting for what the average spend is. The second highest is 940. If we were to just simply transition to that 940 level, then that would reduce our overall healthcare spend by $160 billion a year. 14% of annual US healthcare spend is on billing and insurance administration, which is a total of $500 billion in spend. If we were to just have a central clearinghouse for billing and processing, like Germany and Japan do, then the yield for that alone, just that alone, would be $90 billion per year. If we were to, speaking of prices, cap them closer to Medicare rather than at typical rates, let's not even say Medicare, but at 140% of Medicare, then that would yield about $30 billion of annual spend. And there's also a very clear statement in this article that we need to continue the push toward value-based payments. And I'll be describing a bit more about what those are in a moment. Yes, sir.
Yeah, just a couple of comments there. Recently, our president, he signed off on some initiatives that are going to create hopefully more transparency and lower cost in the area of pharma. I recall, 10 to 12 years ago, the pharmacy expense related to an employer's medical RX benefit plan, was around 10 to 12%. Today, we see routinely that average on the overall spend exceeding 20% of the plan spend, including medical claims. And we've seen it, the worst case that we've seen was up in the mid 30s. So I think that, we're hopeful for sure. We'll see. President Trump is, he's fighting a lot of battles here, but in 3 different areas he signed off on as it relates to pharma, including being able to access some, out of the country pricing. We hear a lot in the U.S. about Canadian pricing, which is less, and certainly he's pushing for that to become available. So we will see. And then one other comment that you made, that you suggested in your slide, which I thought was very good, is in terms of commenting on Dr. Emanuel, was the 140% of Medicare. So we see a real paradigm shift from the employer side within healthcare plans, where many employers are starting to abort the traditional network environment out there, and they're starting to set up reimbursement strategies based on a percentage of Medicare. And certainly that's wrought with some challenges, no question, but we see that going on now in the marketplace. So it's just interesting to me.
Next slide, please. This slide typically just calls out that there are many, but 4 primary forces driving healthcare transformation. Payers, which to a certain degree can include you as employers and others as well. There's a real interest there on getting this under control and changing it. The market is interested in competition and transparency, and that's a driver for us. Patients clearly want a move toward healthcare versus sick care. They want greater shared decision making, and they want an experience and access that matches their needs rather than ours as a healthcare delivery system. And then the workforce, we're really interested in how do we effectively recruit and retain people within healthcare, but also how do we keep people well in the workforce in general so that they can remain productive members of your teams, and then also avoiding burnout. Next slide, please. That's actually, this is one, next slide, please. This slide talks about, this 2 different authors here at the Cleveland Clinic, they were talking about how this feels as a clinician to be a participant in the healthcare system, because that's an important element as well. You'll notice that on one of the prior slides, we talked about burnout. It's very real. They're constantly adding more to our volume of what we do without, in a volume-driven schedule, without a lot of relief of additional items. Each electronic medical record upgrade can make you feel like you're using the EMR for the first time. Things move and they're always in a different place. But only about 75% of the encounter time that you spend on an encounter is not really spent face-to-face with the patient. It's spent managing orders and EMR documentation, which seems backward to people. And there's a continuous publication of sometimes confusing guidelines, or this association or that college has come out with a different guideline for certain types of cancer treatment or screening. And every touch that we provide as a clinician yields more touches. So it's interesting to think about, but there was actually a study back in 2009 that came out of North Carolina that said the average family physician taking care of an average panel of 2,500 patients, in order for them to implement the best practices in the lives of all of those 2,500 patients, would take 21.7 hours a day. That's 21.7 hours a day. And that's back before the EMR became as present. It's just simply not sustainable. And that's part of the reason why we're moving toward team-based care. Yes, Todd?
Yes. We, just an observation here, we see a kind of a growing appetite for more of a direct primary care model as more and more private practices are acquired by, larger healthcare and larger healthcare institutions. We see not only demands from a technological and administrative standpoint, but I have my primary care physician as an example, suggests that there's more and more of a burden on him. In this case, it's a gentleman. In his case, in that from a governance standpoint, the large healthcare, the healthcare system itself is requiring more in addition to just technology. So big burden on you all as providers that want great outcomes to be able to take care of your population. And we have seen in return, we've seen providers out there providing primary care that suggest, I just can't take care of the volume. And really from a moral standpoint, they're struggling. From an emotional standpoint, they're struggling. And so we're seeing direct primary care come into play where they're aborting the large systems. Some of these providers are, and treating a much smaller number of patients. And even their pricing has changed. But the whole idea is they're trying to just gain more face time with them in an effort to develop a relationship and create good outcomes. So it seems like a very tenuous balance that we're dealing with, and I'm hoping more efficiency. You all will be faced with an easier task that will be more efficient. Time will tell, but I know it's a tough battle.
It is a balance, and it is a battle. And what I would suggest would be, while I understand for individuals and maybe for individual patients, individual clinicians and individual patients, how that shift toward direct with smaller panels and all is appealing, we simply don't have enough clinicians, physicians, advanced practice providers to take care of our population in that kind of model. We simply don't. So it's important for us to figure out what we can do to adjust the model that we have until such a time when such a model is feasible for us. So it's important to think, we talk about every system, it produces the results that it was designed to do. Our system is producing exactly the results that it was designed to do. And clearly we need a different approach from both a spend and from a sustainability and from an outcomes perspective. It brings to mind a situation. I'll tell a little bit of a story here before we move on. It has to do with in Honduras, they typically get hit with hurricanes on a periodic basis, and our coast is facing some hurricane work right now, and some hurricane threat. But down in Honduras, they're very vulnerable, and with great regularity, hurricanes come through and hit that area. And they typically, when they do, thousands die, thousands are injured and or displaced, and significant portions of their infrastructure are damaged. And they got tired of that in Honduras some years back and built a bridge that was particularly important for them from getting to one side of a body of water to another. It was strategically important for them. And they built what's called the Cholatuca Bridge. And they had an international company come in and design and build a hurricane-proof bridge. Well, it's interesting what happened. In 1998, Hurricane Mitch came through and hit Honduras. Now, 5,600 people died, 150 bridges were destroyed, 12,300 were injured. But let's take a look and see what happened to the Cholotuca Bridge. Next slide, please. This is the Cholotuca Bridge prior to Hurricane Mitch. Next slide, please. And this is it after. Now, the bridge, at least the difficult part of the bridge infrastructure is still standing. But what happened? The water moved. So, here's where I'm going with it. This is not fulfilling the purpose for which it was designed. The water has moved. And in healthcare, the water has moved as well. We want different things out of our infrastructure now than when we first created them. We want greater emphasis on prevention. We want a lower cost of care and a lower cost to care. We want greater access. We don't want to have to travel from one side of the bridge to the other in order to get to the care that we need. We want it to be present on both sides, where we are, where people live, learn, work, and play. And so it's an interesting story that really highlights the need for change, and it's a structural change within healthcare writ large. Next slide, please. So I believe population health is part of the solution for that. And so what is population health? Well, there are many different definitions of it, but the definition that we use here at the Cleveland Clinic is teams of people proactively learning and addressing the needs of people, seeking to understand, activate, and that's important, and enlist and equip patients to impact their own health outcomes. And then the populations involved include the existing populations of patients that we currently take care of, potential patient populations that we might one day take care of, and then the community writ large that we likely won't necessarily take care of, all of them for sure. What are we doing as stewards of our communities, as anchor institutions, to try to help promote the health of the population and community writ large? Next slide, please. So at the Cleveland Clinic, what it looks like is we have expanded teams that include physicians and advanced practice providers in a dyad. We have nurses, medical assistants, pharmacists, social workers, care coordinators, population health medical assistants, navigators, and patient service specialists. We focus on access that's available when and how people need it, with walk-ins, hours of operations that are extended, and on weekends. We focus specifically as well on shared medical appointments as another way. And then some of our touches have really transitioned to non-traditional touches, that we don't depend exclusively on physician and patient being in the same room at the same time, face-to-face. We have virtual visits. We use remote monitoring extensively. We use messaging within our EMR. We have e-consults with patients and e-consults between clinicians so that clinicians can get second opinions much faster without necessarily having to go through a full referral to a specialist. We do shared medical appointments where you might have 10 to 15 to 20 people with a similar diagnosis in a shared medical appointment at the same time, all getting counsel, all getting guidance and education about their condition. And then we also have scheduled telephone encounters, and we focus as well on warm handoffs across the continuum of care. Yeah, Todd.
Sure. Those are great comments, and that's very interesting to me. An observation we have as an organization is relates to population health, and one of the things that we've seen is pretty fundamental. But what we're finding is a lot of the service providers that are offering benefit plans and benefit plan administration struggle with the advocacy piece. And so we know that healthcare is extremely personal. And one of the descriptors, I think, said activate, and another was engage. And it's critically important. I think, a lot of the providers out there offer health risk assessments, of course. But if a plan, not the employer, but if a plan were, as an example, to mandate health risk assessments as part of certain criteria related to pricing or the benefits they receive, we might be able to identify the population and what the population is dealing with. Certainly, it helps us identify that 5% of your population that's driving 50% of the cost. And then it really positions for an extremely proactive strategy to create outreach to them in terms of treatment compliance, in terms of just helping them to understand what non-compliant can mean to them. And then for the others, not the 5% driving 50%, but the rest of the population, you can identify, hey, you have a certain tendency to experience diabetes at a high percentage rate within your plan. You've got an obesity problem, whatever it might be, it puts you in a position to proactively plan and implement these strategies for your clients. So I think population health is critically important, and appreciate those descriptors you've explained for sure.
Thank you. Next slide, please. I'm going to talk just briefly about a few of the different trends. Typically, healthcare providers have been pretty reactive in the office, in the location, wherever they are, waiting for the patient to come to them. There's a real transition now in our ranks. It's our current and many people's future to be proactive about reaching out actively to help close gaps of care for the patients that we have entrusted to us and to begin to activate them. As well, typically, healthcare has oftentimes been a passive thing from a patient's perspective. Care is something they receive rather than something they participate in. And care is recommended for them, and the doctors say, this is what I need to do, rather than this is a decision that we make together. Because when people have skin in the game and have the willingness to be activated themselves, to be full participants in their ultimate health outcomes, that's where change really begins to occur. But from a physician standpoint, medical practice has really shifted. It used to be, who's on my schedule today? I remember when I started in clinical practice, I had a paper schedule that was handwritten in front of me, and it showed what patients were in which slots on there, and it would oftentimes say nothing next to the patient other than maybe new patient or follow-up. It might say follow-up emergency room. And now the real shift has focused toward who needs our attention, who isn't coming to see us. In addition to who's coming to see us, the focus is on who are our patients and on our panels that need our attention and aren't necessarily coming in. How do we proactively reach out to them? Access has been focused, centralized, sort of the build it and they will come sort of approach. But then there's the real shift toward providing local access where the population lives, learns, works, and plays. So things like having, instead of one centralized location for healthcare delivery, a variety of satellite offices, school-based care, mobile care, as well as virtual care. Instead of aggregating bricks and mortar as the modicum of success in healthcare, it's about aggregating lives in management now. Instead of fee for service, it's fee for value as the transition, with outcomes, experience, and spend being important. We used to have a very transactional approach to healthcare, and in certain ways it still is. I present with an issue, I receive care, funds are transferred, I move on. Very transactional. And we're really looking toward a relational approach, a longitudinal, lifetime-oriented approach toward interacting with people, because it takes a long time to make some of these changes. Individual physicians doing it all to top of competency teams really working together. And then that downstream focus that we talked about earlier, where in the US we have typically focused on the downstream provision of disease care to really move upstream toward health provision and promotion of health rather than just sick care. Next slide, please. A little bit about the value definition. The traditional eloquent definition is value equals quality over cost. We're familiar with it. It's really straightforward, pretty easy to understand. A couple of ways to enhance value. You can either improve the quality or lower the cost or some combination thereof. However, from the standpoint of it being actionable, our approach and our definition of value here at the clinic is a little bit more granular. We broke it down into the what, the how, and to what end. So the what, it's the care that is needed, desired, justified, and prioritized. How, delivered safely, reliably, and affordably. To what end? With the outcomes and experiences that patients, families, caregivers, communities, payers, and I would say employers desire. And so one quick example of how the same care can be high value for one person and low value for another. About a year and a half ago, my mom died. She had an acute diagnosis of leukemia. And in the process of working through that with her, her physician, while she was hospitalized getting the initial diagnosis, her physicians described what they'd like to do from the standpoint of the therapy that they wanted to provide and the chemotherapy. And as she was listening, I watched her. She was a nurse, and I watched her processing this. And I tried not to intervene at all, but was watching really closely. And she said at the end of this, when they said, "Do you have any questions?" She said, "Yes. How will I feel during this time under treatment? Where will I be? Will I be at home? How often will I need blood draws? How often will I need to come to the hospital? What's it actually going to feel like?" And at the end of the day, she decided not to do that. She decided to enter into hospice and go peacefully, which she did actually about 4 days later. But what the point of this is to say, for her, it would have been very, very low value care to proceed down that course of chemotherapy because it wasn't what she desired. Whereas for other people, they may desire it, it might be needed, desired, justified, and prioritized. And if it checks all of those boxes and it's affordable, then that becomes a high value type of care. Next slide, please. So in order to really talk about what people want and what is desired, it's helpful to think a little bit about what patients really want. The research really shows that patients want to be heard and understood. They want to understand the situation that they're in, potential plans that they have, that the care team has for them, and then share in the decision making. They also want to feel that they're being taken care of by a team that communicates with each other and are on the same page. Caregivers, us, those who provide the care, we want meaningful work, and it's difficult to imagine, at least from my perspective, work that's a whole lot more meaningful than healthcare. So we've got that in spades, but we tend to layer on a lot of meaningless work on top of that at times. People want the resources and authority they need to accomplish the work that's been asked. There's not a whole lot more dissatisfying for anyone to have the accountability for something and don't have the resources to be able to accomplish it. And then finally having appropriate rewards and accountability. Next slide, please. What do payers and employers want? Well, they want all of those things as well, because oftentimes they fill one of those other roles. But they also want expense control. They want a productive and healthy workforce. They want fewer absences. They want fewer injuries in the workplace. They want some options available for them for the high dollar and outlier cases that will inevitably occur. And they want employees and members that are pleased with the benefits and, importantly, activated to care for themselves. Next slide, please. So value-based revenue. We talked about one of the things that Zeke Emanuel suggested needed to occur was a greater transition toward value-based care. What does that really mean? It's care that rewards based not just on process of delivery of care and measures processes, but also rewards based on outcomes. And those outcomes are quality and spend. Next slide, please. We've talked about a team-based approach to healthcare and who are really on our teams. You can see the patient population is there in the center of that. And that's really our focus, patients first. But around that, you'll see within each team, there'll be a primary care physician, or if it's a surgical home as well, there'll be a surgical physician or proceduralist. And then there's an advanced practice provider, a nurse practitioner, physician assistant who works in partnership with them. Then there's a medical assistant. Surrounding them, we have built registered nurses, care coordinators, patient service representatives. Around them, where appropriate, we have physical therapists, nutritional counselors, behavioral health social workers, pharmacists embedded in our practice to help optimize both outcomes and spend for our pharmaceutical interventions, connected care providers that do virtual care, population health medical assistants, as well as health coaches. We also have centralized resources that you can see on the right, and then geographically proximate care, such as express cares, urgent cares, chronic disease clinics, wellness, etc. Yes, Todd.
Yes. Doctor, this looks and describes to me much of what a medical home model is defined as to a certain extent. So within this landscape and in terms of an episode of care, and how you all are collaborating and communicating. Can you speak to, just for a moment, the dynamic that exists when you have primary care and it's described as advanced practice provider, but let me describe it as primary care and then specialists that may be needed.
Yep.
Maybe you've determined even in advance based on criteria. Tell me about that communication. Are they on situs many times within your model, meaning on situs and actually in the same location, et cetera?
Great question. This diagram really speaks to the structure. The function is certainly follows the form, but it's important to note some differences that are not picked up in this. One of the things that our teams do on the primary care side is we have panel management time where our teams literally stop caring for patients for a period of time, an hour block, 2 to 3 times a week. And the population health medical assistant pulls down a list of patients that have needs that aren't coming in, who has poor control of their diabetes, whose hypertension is not coming into to management well, whose lipids are off and not meeting the measures, whose vital signs based on our remote monitoring program are starting to trip up and show that there could be a concern. And those things are discussed as a team, literally working together, working on that and determining some prioritized actions that can follow that. As far as are the specialists on site, in some of our locations they are, but in some of them they're not. But in every one of our locations, they're accessible through those e-consults that we described, where we can get a very quick second opinion from one of our specialty colleagues. And each one of our specialty institutes has one of their physicians on call on any given day for those types of e-consults, so that anyone, anywhere within our system can reach out and get that nugget of information, that pearl that's needed in the moment to try to optimize outcomes. So that's part of how we really created that seamless network.
Excellent, thank you.
Next slide, please. Analytics are really, really important for how do you manage a population as well. Now, clearly there's the low risk population, the relatively healthy, and you focus on wellness and prevention with them, trying to keep them activated and thinking long-term for their health. Those with rising risk need some panel management and some chronic disease programs. They might have 1 or 2 comorbidity. They also might need some social and or behavioral health support in order to be able to be really adherent to the medications and the regimens that are there for them. But then there's the really high risk set of patients that need intensive home care, intensive care coordination, and more of maybe a comprehensive or geriatric approach to this. Now, there's a lot of things that you can do with these analytics, but it is absolutely vital to prioritize your focus based on these analytics. And we've done so. Every one of our patients in our healthcare system has a risk score that is very clearly visible in our EMR. We built this risk algorithm ourselves, and it takes into account about 125 different variables that include laboratories, utilization data, as well as patient entered data about how they're feeling and what they're doing. And all together, we can come up with a risk score that is clearly visible. And then as clinicians, we can highlight that risk score and drill down into figuring out which specific levers are actually contributing to rising or high risk, so that then we can form a plan to mitigate that risk and lower it. Next slide, please. You've heard the discussion about social determinants of health, and it's become very clear over the last 30 years or so that only about 20% of a population's health is determined by the health care that it receives. And we as clinicians kind of initially take offense to that because we want to think we're really the ones that make it all work and make it all hum. But the actuality is that that's not the case. 80% of it is determined by other things, such as the physical environment, health behavior, social and economic factors. And so it's important for us from a population health standpoint, if we want to truly impact health outcomes beyond the 20%, then we need to take those other things into account. And we're doing that as well here at the clinic, and many other health systems are as well. Next slide, please. This is just an appetizer for next week, but we're going to talk a little bit about how well are these programs working. Well, we have a house calls practice that has lowered the reduction in cost of care for that subset of patients by 28%. We have care coordination program that is quite vigorous, and that in and of itself has lowered the cost of care by 12%. Now, all mind you, this is while improving the true outcomes and experience for the patients. And then we also have a program focused specifically on emergency room super utilizers and reduction of inpatient hospital days. So for that population, we identified them, we drilled down into what the risk factors were, and then we've created individualized plans of care for those patients, and we've seen a 49% reduction in hospital days for that subset of patients. So that's the appetizer. We're going to talk a little bit more about it next time. Next slide, please.
Quick
Oh,
question.
yeah, please.
Yeah, quick question, Dr. Myers. You referred to the importance of analytics, and a lot of us on the call, and certainly those within our organization, we understand that, and we utilize a variety of different tools, from advanced plans for health to internal data analytics, et cetera. But in terms of just your organization, you're the provider then, but again, I know next week you're going to be speaking to this, but did I hear you say correctly that you all developed your own metrics and your own analytics internally?
We did.
Okay.
We did. And it's important, and we'll talk about this a little bit more next week as well. It's really, really important for all levels of this in partnership surrounding people's healthcare to be appropriately providing access to the data that are needed to those providing the care. It's sometimes difficult within the payer-provider relationship to get the information that we need, the data about what's occurring with patients when they're not in our system. That is really crucial for us to provide the best care for them. So as you're looking to build your benefit structure, focusing on ensuring that there's good data flow between the insurer and the payer, and the providers who are in your networks is really critical for the work, because that's how the work gets done. That's how the traction is gained, is with complete information.
Sure. Next
slide, please. So how has COVID affected healthcare? Well, I will say there's likely not an aspect of our society writ large that has not been affected by COVID-19. And certainly that is the case within healthcare. There's been a dramatic transition toward virtual care. When all this started, about 2% of our ambulatory care was being provided virtually. During the peak, we were at about 85% or so of our care was being provided virtually. We anticipate that we'll settle back down somewhere around the 35 to 40% range. At the end of this year, about 50% of hospitals will end the year in the red. They will have a negative operating margin. This is secondary to a variety of things. They've lost volume of some of the higher reimbursed procedures, the elective surgeries, et cetera, all while they've incurred higher expenses, both for supply, for PPE, and for overtime for the workforce, oftentimes caring for surges of patients. Additionally, we've encountered a significant rise in unemployment in the United States. And as people shift off of commercial being employed, they oftentimes lose their commercial insurance. Some of that is carried over by a gap of COBRA, but many can't afford that and will flip pretty quickly into either no insurance or Medicare or Medicaid insurance. And so there's a change in the payer mix. So even when volume returns, as we're seeing right now, it is with a substantive shift in the payer mix, depending on what your demographic is. So that is eroding the bottom line for hospitals and health systems. And frankly, at the end of the day, not all will survive. I would suggest that maybe 20%, this is just me, 20% of hospitals may not ultimately make it through this, depending on how quickly we can get vaccinations, et cetera. And then also, private physicians who are out there are less equipped maybe to do some of this population health work and shift their way that they get paid toward value and more focused on traditional volume of care. And because of that, they've suffered mightily during this time. And I imagine many of those physician groups will close and or be acquired. And we're beginning to see those transitions now. So those are some of the things that we see happening secondary to COVID, and we can talk more about that. Next slide, please. So the next time, we're going to talk a little bit more about these trends, what can and what we think will be done about it, and what we might be doing about that, how the Cleveland Clinic has bent our own internal cost curve for caring for our own, and then we'll also talk a bit about some other things that you can consider as you enter into the open enrollment time and think about benefit structure for your own employed people. And with that, I will conclude, and the floor is yours, Todd.
Yeah, thank you. Thank you for your comments. I think much of your information is it prompts just a lot of thoughts. We all, from our perspective, and many in our audience, I know, we do describe what we're going through as a paradigm shift, and it's a paradigm shift in a variety of different ways. In the midst of that, we are dealing with the COVID pandemic, so that even exacerbates and makes it feel more like a paradigm shift. But it'll be very interesting to me next week when we talk about your plan, the Cleveland Clinic's plan, and what you actually do, fundamentally, internally within your plan. So I really look forward to that. I have a question that came in, and this is a very good question. A couple of those I'd like to address here. One of our viewers asked if we will be talking about emerging technologies in healthcare. And the answer to that is we will talk about that a little bit in next week's session, because I know some of the strategy and the deliverables that Cleveland Clinic has deployed internally. And so some emerging technologies will be kind of an offshoot discussion of some of that. So I wanted to address that question. Another question that came in is, how long do we have to wait for true transparency? And I love that question. I love the question. And, we as a firm, we are really, really moving forward and being as progressive as we can in that respect. I don't know the answer to that question. That is the $1 million question. And then I also am extraordinarily interested in, when we have true transparency, what percent of the population will understand really what it means? It's kind of like if we're having a challenge activating and engaging a population today, and we clearly can provide, or providers can provide them, the metrics that show why it's important to do so, then it lends to the question, why are we still having issues with a certain segment of our population that we just can't engage? So, but I do think the question about transparency is critical, and I think it's extremely, extremely important.
Transparency is better now than it has been. It is not what it will be, and how we transition to that will take a bit of time, but we will make those transitions. And you're right. I mean, it is time for a paradigm shift in things. To go back to an earlier slide, the water has moved, and it was moving pretty quickly prior to COVID, but now COVID has just picked up that bridge and moved it away from the water to where what we were doing before as a health system, not Cleveland Clinic, but health system writ large, and then the public health system, the supply chain, simply was not prepared for this. So in order to do something different, we're going to need a different delivery system to really accomplish better results.
Yeah. Two other questions I would like to address, and Megan, hopefully that leaves us enough time for you to professionally end our session. But one of the other questions that came in, which is a great question, says, with the potential of 20% of hospital closings, do you see the majority of that being in rural hospitals? If so, how does that affect the model of having healthcare where patients work, live, play, etc.? And I know here in Oklahoma, there is no secret about it. In Oklahoma, rural communities and hospitals are really struggling. But Dr. Myers, you have a thought related to that?
I do. Certainly, we will see some that close in rural areas. I imagine that the critical access hospitals will be a little less likely to be on that list. They have a different payment arrangement with CMS, Center for Medicare and Medicaid Services, that they get a more of a cost plus approach. So they may have some protection as a true critical access hospitals, but not all rural facilities are critical access hospitals. I know that there's a lot of advocacy underway on a lot of levels to try to help ensure that those safety net facilities can remain open. They tend to run at tighter margins than some of the other healthcare systems, but I would also say that rural hospitals are not the only safety net facilities. Oftentimes, metropolitan and inner city hospitals and urban hospitals tend to fill just as significant a safety net role for even larger populations than in the urban centers, and they're particularly vulnerable as well. And not being critical access hospitals, they don't have some of the same protections. You know, at the end of the day, there have been statements made prior to this that we probably had maybe 20% or more of overbedding in the United States. In other words, too many hospital beds for what we need down the line, what we need at the current, and certainly what we need down the line. This is a tough way to go about changing that. I still think we will end up with enough beds at the end of it, but it'll be in fewer hands, I suspect.
Yeah. One last comment I'd like to make. One of our viewers asked the question, what does it mean to be transparent? I think that also is a very good question. It's kind of like historically, you hear the idea or you hear the descriptor wellness. It's like, okay, how are we really defining wellness? Because it has, you know, it can go in a lot of different directions. Transparent to our organization means if I, as a consumer, need care, I have the ability to vet alternative providers that may specialize in an area. I have the data needed to be able to gauge quality. I have all the data needed to be able to gauge price.
Yep.
I also have all of the data needed to help me understand if I am having to access care through an insurance, some sort of insurance deliverable, to understand what my exposure is and what my cost is. So that applies to medical, that applies to pharmacy, it applies to all of those core competencies that we have to face within an episode of care. So
there's one other layer of transparency that I'll emphasize that you didn't delineate specifically, and that is transparency about why certain procedures are actually necessary.
Yeah. Absolutely.
You know, is this MRI really needed? Is this surgery really necessary? Or is there another course of action that we could take that would likely yield the same results? Time after time, we're finding that there are studies now in the literature that show, you know, conservative management of a certain type of disorder versus aggressive management with an intervention. Immediately, short term, 6 months to a year, maybe the folks with the intervention do a little bit better, just maybe a little bit better in certain cases. But long term, more and more, we're finding that at 2, 3, 4, 5 years, the outcomes are the same. Yeah. So the question then becomes, are we informing our patients about those facts? And is there shared decision making, not just about where I get the care, when I get the care, but what care I actually get and or need?
Yeah, great comments. Great comments there. And certainly we've seen statistics regarding unnecessary care, and we can talk about that more at another time. But Dr. Myers, it's been a real pleasure. Thank you very much. I'm honored to be able to sit with you through this. Thank you to all of the attendees. We appreciate you very much. We want to be a resource to you. We want to be, we want to be meaningful and intentional in terms of what we're doing, and we're hoping that provides value to you. So with that, Megan, I'll turn it back over to you.
Thank you so much. I'd like to thank Dr. Adam Myers and Todd for their time in sharing this valuable information with us today. And we would like to thank all of you for joining today's session. Please be sure to follow us on social media. Part 2 of this series is scheduled for next Tuesday, August 11th at the same time. In that session, we are thrilled to have Dr. Myers return to provide an update on healthcare trends, how employers and employees are affected through these trends, and how organizations can prepare moving forward. We will also dedicate time during that session to answer any questions we receive from our audience. So if you do have any questions over the next few days, we encourage you to please email them to either Dr. Myers or us at marketing@yoursummit.com. So please keep an eye out for information, and hopefully you'll be able to join us for our next session. We also have COVID-19 resources available on our website, so please take a look at that for more information. But for now, thank you so much for joining us. Have a great rest of your day and stay safe.
Thank you.
Thank you.